This is Matt Borchardt with CliftonLarsonAllen. I work with Deb Freeland a little bit out of the Indianapolis office, and I was hoping to talk to a few of you guys today about just our way of analyzing gold standard performance and what the new drivers of value might be. And how this presentation is kind of set up is it's meant to say, well, we've been doing this analysis of critical access hospitals for about a decade. So it's a way to kind of look and say, okay, what was the old drivers of success or how we deemed success back in the day, and then where is the world turning to into the future? And then after we look at a whole bunch of ratios and a whole bunch of different analysis, where do you sit on the whole new strategic paradigm where you're going to want to lower your total cost of care? And total cost of care is more defined as it's your revenue to your organization. When you're lowering total cost of care, it's not necessarily lowering your expenses, it's lowering your revenue, so it's the cost to the insurance companies. So after we do all that, we'll kind of compare Indiana also a little bit to the national medians and our new defined gold standard critical access hospitals also along the lines. So first thing, we'll just kind of go over our understanding and how we measure value in our analysis, and then how we identified what the critical access hospital gold standard performance hospitals were. And then what were the key results and the indicators of value. And then we'll go through the new strategic paradigm a little bit and compare Indiana to other states, because it's really interesting to see how each state, they've developed differently over time. They just have different demographics going on. They have different state payment streams going on. They have different competition, so they've just grown up differently over time compared to other states when you map them all onto a table. So how did we measure gold standard performance in the past? Well, gold standard performance to us in the past was all financially based. So it was basically the organizations that had the greater profitability and the higher cash were the ones that were the high performers and the gold standard performers. And our goal was to try to identify who the best were and then start to try to measure them and learn from them to help other organizations improve themselves. I know it says be the best in the bottom corner, but a lot of organizations don't have the makeup that these organizations have. They might not have the huge subsidies that some of these hospitals were getting. They might not have the great payer mixes and things of that sort. So it's hard for certain towns, and they might not have the size to become a gold standard performer. But it was all a methodology back in '03 that we kind of tried to put together to identify who were the best. And the big genesis that kind of came out of that study was how to measure them. So we created our debt capacity index. So it basically allowed us to look at the financial performance. So the left side was the income statement methodologies that we might look at for the financial statement performance. Then the right were the balance sheets ratios that we might compare. So debt to cash flow, well, that was the debt service coverage, and that was weighted the highest out of all of our ratios, is most important to get to our debt capacity index, and we still use this ratio today. We had the debt to equity for debt to net assets, and the debt to cash reserves, which was cash to debt, and when you'd weigh all those together, it would give you how much debt capacity each organization would have. So how did we weigh it? Well, like I said earlier, 75% was based off the profitability of the organization, so that was the debt service coverage, but we did weigh cash reserves also about 15%. And after that was all baked in, we realized that there was kind of a pathway and common themes that these organizations had that were successful. So these were our old pathways to success. So it basically was, did you have sufficient revenues? Did you have good cost performance? Another big key was the strong procedural and ancillary services. Did you have outstanding physician relationships and aggressive growth? After we started to do this a lot, we also realized that another huge and probably the most important factor in financial performance all runs down into what is your payer mix and how good of payment streams do you have from your commercial payers. So when you compare and put the correlation to every single ratio and every single stat on a cost report, the stat and the ratio that matters the most to how strong your financial performance was or your debt capacity index was how much were you getting as a percentage of Medicare for your non-Medicare book of business in your hospital. So how have the hospitals compared from that analysis to today? A couple neat things is that in the last 8 years, operating revenues have gone up on average 9% a year. And the performance indicators, and this is a lot to do with payment streams changing up lately, is they're just not as strong as they used to be. But these organizations are putting a lot more into cash, and they have stronger balance sheet ratios. And they also have newer facilities than they would have had in the past. A lot of them also have spun off their nursing homes and also are utilizing the provider-based clinics as an additional revenue source. Their Medicare ratios and their cost-based utilization is actually less than it has been in the past. And they also have lower FTEs, and their costs have gone up a little bit, but they're not like as going up typically as much as the revenue's gone up over time. So what's really changed? In the past, our definition of value was basically optimizing financial performance. Well, now we look at it and it's all about total cost of care. So you want to have low cost, and remember that total cost of care is actually your revenue. B, you're going to want to have high quality in the future. So this is looking at processes and outcomes of care from the Hospital Compare website, patient satisfaction, all that from the Hospital Compare website. And then you also want to look at community health. What are the behaviors of your area? What are the actual outcomes of health in your area? And all these put together are what create value into the future. That's how we're defining value into the future. And these are definitely transformational times. Yeah. Someone have a question? Okay, I'll keep going. So what we ended up doing.
We just had someone else join the line, Matt. That's all.
Oh, okay, perfect. So what we did is we thought about it, and it's actually kind of a four-sided pyramid, and it's creating the CLA value triangles. So the first triangle is financial management, and this is all the information that we could get from the cost reports. So this is the old way that we used to look at analyzing what value was for a critical access hospital. But now we've kind of added up 3 other key pieces. So the first piece is services and utilization. So that's kind of the provider makeup in the area. How are your overall costs for Medicare enrollees? This is all the information that we kind of got from the Dartmouth Atlas data set and brought that into our critical access hospital analysis. The next one is kind of this quality and patient satisfaction, and this is all from the Hospital Compare data set, and this is your quality processes, your outcomes, your HCAHs. And then we're looking at community health, and this is from the Robert Woods Johnson Foundation, and this is looking at what are my factors. So what are factors would be what kind of health is my county in, and then my outcomes would be, well, what are my premature death rates, what's my morbidity, and items like that. We'll go over that in a little bit more detail here in a second. So when you look here, this is all the data sources that we've kind of added to our critical access hospital analysis. So in the past, we just would take the the Medicare cost reports, and we'd analyze the heck out of it. We'd have 1,000 different ratios. But now with the new transformational times, we've decided to also incorporate some of these other items like the Dartmouth Atlas database to look at services and utilization. We're now pulling the hospital compare databases to look at quality and outcomes, and then we also are getting the patient satisfaction data sets from there. And then we're also looking at the community health of these different counties that the critical access hospitals reside in, from the Robert Woods Johnson Foundation. And we're trying to bake that all in together into one big analysis to identify what is value with these new critical access hospitals. So how we're coming up with like community health, for example, from the Robert Woods Johnson Foundation, is we're trying to make sure, we're looking at the health factor rankings, which the health factors are based off of how healthy is your county, and that's based off of healthy behaviors, so that'd be tobacco use, diet and exercise. What's the clinical care like in that county? What are your social and economic factors? And then what's the physical environment? And they all bake into what the factor is for that county. And then the health outcomes is looking at both mortality, which is any premature deaths, and then morbidity for your county. And the only way that you could become a gold standard hospital is if this community health differential was positive, meaning that your factors, your outcomes were better than your factors said that they should have been. So a couple things that were kind of neat when you start looking at this, when we came up with our methodology for utilization, I mean, physical inactivity led to higher utilization. That had a correlation. Increased diabetes also had a correlation with utilization. The one thing that kind of didn't make sense was excess drinking actually led to lower utilization. But once you started to look at the ratios, it almost seemed like the counties with higher social and economic factors also had higher excess drinking. So that was kind of why that led to it, but that was kind of a unique correlation. So when you baked all this together, we wanted to have a new methodology to identify what gold standard performance was. So our first step was our same process as in the past, and this is you had to be in the top quartile of the debt capacity index, and that was that table that we went through about slide 3. And then we baked in all these new outcomes, and they are a little exclusive on small hospitals because for quality and patient satisfaction, they must report the data, and a lot of small hospitals just don't have a large enough pool to report the data. It's not a lot of them, but they automatically were excluded from this gold standard performance. But then on every single process of care and every single HCAHPS, they could not be in the bottom quartile. And then the community health ratios, we wanted to make sure that they had the positive community health factors, so that means that their outcomes are better than their factors suggested they should have been. And when we included all of that and looked at our gold standard performance, basically 22 hospitals in the nation met this criteria, no more. It was just 22. And where were they located? Well, they're kind of located mostly in the upper Midwest. Minnesota, Wisconsin had 4. Indiana, actually, you guys had 2, and they were Margaret Mary and St. Vincent. Those were the 2 that met all of our criteria for high performance. So let's just start looking at some of the different ratios that we kind of compared Indiana to the rest of the nation and to our gold standard performance. So the way that you read a lot of these is if they have these quartiles, the lower you are in the quartile, the higher the performance, and the higher you are in the quartile, actually the lower the performance is. So for debt capacity index, Indiana as a whole actually has a little bit worse debt capacity index than the median would. And then debt capacity as a percentage of revenue, you can see Indiana has quite a bit less than the other non-gold standard critical access hospitals, and then also the gold standard critical access hospitals. The other peer group we have in here are large hospitals, and then the top quartile and debt capacity index of large hospitals, because it seemed like when we did a correlation of the ones that were high financially performing actually had, on a lot of cases, a lot of the other ratios that weren't even financial based had stronger performance there too. So quality and process of care, definitely better than average here, and outcomes of care, you were slightly below average, and outcomes of care are like the readmissions and things of that source from the hospital compare data set. And both of these ratios actually are comparing critical access hospitals compared to all the hospitals in the nation. So the PPS hospitals are actually included in this data set. So then on the HCAHs, critical access hospitals typically have high patient satisfaction. So that's why everybody's in the 25th percentile or better. And their average HCAHP score were, in Indiana was slightly worse than your peers, but it was still a lot higher than like all the rest of the hospitals as a whole. And then when we look at county health factors, the factors for Indiana actually are slightly worse with a 2.71 than they are to the rest of the counties in the nation, just on average. And the outcomes were really consistent to where the factors were. So one thing that's really interesting to look at is these gold standard hospitals. It's not like they're in really healthy counties per se, but their outcomes were way better than what their factors said that they should have been, where Indiana was more consistent, where they're both about the same quartile as they were in the past. So if we look at some financial performance metrics, on the operating EBITDA, there's nothing really exciting here. You guys are right in the ballpark there. Days cash on hand, you're slightly higher, but still right in the ballpark. Patient service margin, you're a little bit higher than your peers, but not a ton. And then your other revenue sources, you're slightly worse. The one thing that was kind of neat to see was actually with your volume growth, you're way higher than any of the other peer groups. And then your net spread was also higher than a lot of your other peers in the state of Indiana as a whole. Another really important ratio when we look at financial performance in the hospital, and I've mentioned this before, is the non-Medicare reimbursement as a percentage of Medicare. As you can see, you're about 119%, and that's higher than like the rest of the critical access hospitals and higher than most of the other large CAH hospitals. So that's very strong. So after we've started to bake in all these ratios, we'll see it a little bit later, but I was just kind of taken aback that if this non-Medicare reimbursement is a lot higher, then why isn't the financial performance and the debt capacity index a lot higher? And the big kicker after you really look into the details were actually a lot of the facilities in Indiana were a lot newer, so your average age of plant was a lot less. So that's where a lot of that debt capacity must be going to, just at a high level. Your charges compared to your peer groups are definitely pretty high, but right in the ballpark with the large CAHs. So this slide kind of depicts that the average age of plant going up that was really low that I was mentioning earlier. The average age of plant in Indiana is 8.1, where all their non-CAHs is 12, or the gold standard's 10.2. So it is a very, very low average age of plant. It's probably one of the lowest that I've ever seen when I've looked at a state as a whole. But all the other ratios are pretty much in line with where you'd want them. There's like your cash is a little bit lower and your debt's a little bit higher, but that's all probably because of having an average, very low average age of plan. When we look at some other financial performance ratios, your overall markup, which compares your charges to your costs, is way higher than a lot of the other states, and your Medicare bad debts as a percentage of Medicare revenue are also a lot higher. And when we go into a little bit more detail, the county health rankings, you'll also see that your unemployed is a lot higher too. But as we keep kind of going through, there's a whole bunch of cost indicators that we look at, but none of these really jump off the page when you kind of look at them to me when I did my pass, but it was all part of the analysis. So this next section's pretty interesting to me, at least. When we're using this is all mostly from the Dartmouth Atlas data set. Your primary care provider ratios per 1,000, you want it to be lower because that means you have more physicians, but in all actuality, it's really high. So it kind of says that the state of Indiana as a whole probably has a larger primary care shortage than the rest of the nation. And then the other thing that's actually pretty unique is that normally when your providers are low, your Medicare reimbursement per enrollee is typically lower, but that's not the case here. You have very, very high Medicare costs as a whole. And this ratio also correlates pretty directly with how high your utilization is. So when we look at a couple of these key indicators for the services and utilization, you can notice that your population is typically larger than the other critical access hospitals around the nation, which is to be expected. But the thing that really jumped off the page to me is your outpatient Medicare cost per enrollee is actually pretty much in line, but the inpatient and then the physician and provider are just way higher Medicare cost per enrollee. And then also, as we went over earlier, your primary care providers are a lot lower than other states. And then when we look at some quality and patient satisfaction ratios, nothing really jumps off the page, but your quality typically is higher than the other non-CAH hospitals. That's the 93.8 compared to the 91. And then your outcomes are slightly worse than some, but they're pretty much in the ballpark. So your average outcome is a 16.6, which is actually less than the non-CAH standards, but it's a little bit higher than the gold standard, but it's right in the ballpark. Patient satisfaction, again, nothing really jumps off the page here, and everything's kind of right on target. Then when we start to look in the community health factors, then also things kind of get a little bit interesting. The primary care ratio, provider ratio also is low. The dentist per 1,000 is low. And then when you look at the health factors, some of these are really high. Like the adult smoker is 22.5%. The obese adults are pretty high. The physical inactivity is definitely a lot higher. The excess drinking is actually a lot lower, which correlates to the comment I said earlier that it seems like the lower the excess drinking is, the higher the utilization for some reason. It's more a social and economic factor, but that was just kind of a unique twist on everything. The teen birth rate also is a lot higher than a lot of the other counties. Children in poverty is another ratio that really stuck out, and the no social emotional support is another ratio that stuck out. Violent crimes actually are a lot less than a lot of the peers. And then your recreational facility access per 100,000 is also a lot less, which might correlate to the physical inactivity. And then the access to fast food restaurants is actually quite a bit higher. So then when we look at some of the health outcomes, the premature deaths are, I mean, they're quite a bit higher than the rest of your peer groups. And then some of your morbidity, the morbidity ratios are also quite a bit higher than some of the peer groups. So what happens when we kind of merge all this together? This is our new strategic paradigm when we merged all of these databases together. So it's basically trying to come up with what the total cost of care is, and that's the revenues to the critical access hospitals. And we get that by trying to identify what the net price is per unit and then how high your utilization of your services are. So the higher your costs, like per unit are, the higher the dot's going to be on the table, so it's up to down. The higher utilization is going to be, it's going to be to the right. If you have lower utilization, it's going to be to the left. So then that created basically 4 quadrants. So we had quadrant A, we had quadrant B, C, and D. So quadrant A is typically where the gold standard hospitals basically fell into on average. So they got high revenue, but then they also had low utilization. Some states are a lot of really low payments per unit, some are really high utilization, and we'll show you a couple different states just to kind of show you how this all works together. So how did we map it? So for the price side, what we did is we basically looked at the non-Medicare reimbursement as a percentage of revenue, as a percentage of Medicare, and this is trying to depict how much the commercial insurances have to pay for your services. So you have great commercial contracts, typically then you're going to have a much higher commercial payment rate than your non-Medicare reimbursement. And to get to this non-Medicare reimbursement as a percentage of Medicare reimbursement, this is as a percentage of Medicare PPS reimbursement. We do a high-level analysis to take what you got as Medicare reimbursement and then say, okay, well, if this is what we got as Medicare reimbursement, this is what we would have gotten as a PPS hospital, and then use that as kind of our baseline so that everybody's kind of at the same baseline. Because if you have a new facility or you have a very high cost facility, sometimes that would skew the averages quite a bit. So basically ideal, we'd get the actual commercial reimbursement as a percentage of Medicare, and we've actually done a couple states where we've looked at just like the state of Minnesota, we've actually gotten down to that detail for the entire state, but when we did this high-level national detail, the cost report doesn't allow you to break out just commercial only. And then for utilization, after looking at the Dartmouth Atlas analysis, basically what they really showed was that the higher the Medicare costs were per enrollee, after it's price, age, race, sex adjusted, basically said, okay, well, then that's actually a very good indicator of where utilization is. So that's our baseline of where you fit on the utilization scale. So what utilization scale was Indiana? Indiana had a very high utilization, so they're in the 75th percentile quartile. And then they also are fairly high price, and this goes back to our 119% of non-Medicare reimbursement as a percentage of Medicare. So when we kind of bake all that together, the gold standard performers, as I was saying a little bit earlier, a lot of them actually fit into this quadrant A. So you got high payments per unit and you got low units of service. And this kind of lets you see where you are on the scale. So where does Indiana fall on this scale? As you can see, they're very high on the revenue side, so they're very high for the payment per unit, but then their units of service are also high on average. And the thing that's really actually unique is there's not a single hospital that fell into the C quadrant in the state of Indiana. So let's compare Indiana to a few other states. So if we compare it to Michigan, all in all, they're just low utilization hospitals is kind of the way that those hospitals in that state are. And it's just really uncanny how different states just kind of trend different ways. So then if we keep going through here, the Illinois hospitals actually have, on average, higher utilization and higher cost, but more of the higher utilization. And then if we look at your other neighbor, Ohio actually trends a lot like Indiana does. They're both high utilization, high cost hospitals. Then when we look at Kentucky, basically Kentucky is just straight high utilization. Also, very few hospitals fall into the low utilization category. And then when we look at a whole bunch of the hospitals in the southern United States, so Texas, Kansas, Oklahoma, Missouri, those hospitals actually have very, very low cost on average and typically higher utilization, but mostly low cost, which is, it's just kind of uncanny when you look at all the hospitals in total, how each state, they're just so similar to each other. And then when we start analyzing these different quadrants to like all the different peer groups and for these different ratios, the one thing that was kind of insightful to see is you could see which ratios correlated more to utilization and which ratios correlated more to price. So when you look at these ratios, that capacity, that very strongly correlated to price. So you'll see like a straight line. Operating EBITDA correlated very strongly to price, so you'll see a straight line there. Patient service margin did too. But once you start looking at some of these other metrics, like other revenue, that's probably not the best example of it. Non-Medicare reimbursement as a percentage of Medicare correlated pretty strongly to price. So did inpatient charges per day, correlated pretty strongly to the price side. Now when you look at utilization, so Medicare cost-based utilization, if it weighted closer to the utilization of a specific hospital, they make almost this like little W. So you can kind of say, oh, that's an overall cost per adjusted day. That kind of more was a utilization factor than it was a price factor. So as you kind of go through, you can see which ratios, so both of these quality ratios related more to utilization than they did to price. As you kind of go through a lot of these different ratios. So what is this new strategic paradigm supposed to tell anybody? Basically what the new strategic paradigm is supposed to say is, in healthcare there's going to be a new Southwest effect, so we kind of named it after the airline, where you're going to want to lower your cost and lower your units, but unless you know where you are on the scale, you don't know what you're going to need to do. So if you go and you look at the different quadrants, if you're in quadrant A, your cost per unit's high, but your number of units that you're performing is low. So really, all you really can do is become more efficient to get to this lower quadrant C. When you look at quadrant B, this one, since you are high cost payment per unit, you can get more efficient, but also you can do care model changes and you can flex some costs. So as you lower your utilization, you can also lower your staffing requirements. Quadrant D, you don't really have a lot of efficiency to gain. You're probably fairly efficient as it is. It's more, you're going to have to do more care model changes and you're going to have to flex more costs out of the system. But if you're in quadrant C, which a lot of weaker financial performance hospitals are in quadrant C, you're providing a lot of value to the system. I mean, you don't have high utilization. The commercial insurance companies for the commercial enrollees in your area, they're getting a great discount because you're doing a great job of keeping costs low and also keeping utilization low. So you have to try to find some way to capture more of that value that you're actually creating for the system. So when we look at this, the couple of keys for this creating like a more operating framework is, one is to reduce fixed costs. If you got non-fixed costs, they kind of fall into two different buckets. So if you can decrease your cost per unit, that's becoming more efficient. And if you can take out a whole unit because you're taking out volume, that's more flexing cost. That's kind of how we looked at it. So those are the kind of the big main approaches to lower your cost. And all of this means to lower your total cost for the volumes while the volumes are declining into the future. So some of my concluding thoughts are, A, these are definitely transitional times for rural hospitals, and there's so many bogeys that are coming out into the future. Medicare, if they instituted the 10-mile rule, that could impact a lot of critical access hospitals, or if this new urban designation, if that impacted a lot of critical access hospitals, that could be, losing your Medicare reimbursement could be a huge thing. A lot of commercial insurances, at least in the state of Minnesota, Blue Cross Blue Shield, and went from paying percentage of charges to a new EAPG rate, which is on average going to pay our hospitals in the state of Minnesota roughly 25 to 50% less in some cases. So that's something that's being rolled out, I would imagine, almost in any state. And then another thing that you want to do is you want to basically understand what value you provide, and that'll be critical to your future success. So you want to make sure that you know where you are compared to your peers, and make sure you're trying to be the one with the lowest total cost of care. And it's not like you want to make sure you're there, because you also, if you lower utilization, it's going to decrease your net revenue, but you want to know where you sit to your peers at the very least, just to make sure you understand your value you're providing to the system. And another thing that a lot of hospitals, they're understanding a lot better than they did like 3 or 4 years ago, but when they always heard, oh, we got to lower the cost of healthcare, everyone instantly thought, oh, we got to become cheaper in what we do. Well, in a way, you got to become, it's not a cost, lowering your staff, lowering your FTEs. While you're probably going to have to do that, it's basically taking a hit on your net revenue and finding a way to make sure the organization works into the future. And it all is going to depend on your ability to bend performance beyond traditional methods. So the traditional method for the last decade seemed to be revenue optimization. Whenever we had costs, we had bogeys to hit for our operating margin targets, it was more how do we increase our revenue on our top line to get there, more than it was to cut expenses, but that might be changing in the future a little bit. So what we have going on here internally is we have interviews with and we've already interviewed probably half of them, of the 22 identified critical access gold standard performers. And what the interviews are basically, we're trying to identify what key things actually contributed to them being gold standard performers. What things might they be doing? What unique things might they be trying in their hospitals? And we're going to add all those findings into our final study, which should be available in the late spring of 2014 is what we're hoping for. And when that all gets available, we'll also be putting out the databases that were used in this presentation, so that you can kind of take them home and you can kind of compare your hospital to the other hospitals after everything's kind of fully baked. But that was my analysis of the new strategic paradigm and comparing critical access hospitals and where different organizations lie and what makes different areas different. Well, I'd like to thank everyone who joined in on the call today. And have a great rest of your day.